Thank you so much for the kind introduction. It's my absolute delight to be here and present to you about needle navigation in interventional oncology. Professor Katsanos, in his previous talk, gave an excellent scientific review. My talk is going to be a bit more technical, since we are focusing on a very technical point. These are my financial disclosures, none of which have nothing to do directly with the content of the current presentation. And I'm going to start with a walk to the past. Advances in navigation started, up to my knowledge, back in 1994. This is Afshin Ganji, combining CT guidance with fluoroscopy inside the CT suite. This was the first attempt, up to my knowledge, of combining two different modalities in order to augment navigation. Approximately 5 years later, a guy from Innsbruck, Reto Balle, actually realized that if we're going to speak about stereotactic navigation, we want the patient to be immobilized. So this is the publication about this matrix, which is used from 1995 all the way up to nowadays in order to have the patient immobilized. Especially if we are speaking for table-mounted or for floor-mounted devices, it is, I would say, malpractice to perform needle navigation without this kind of matrices in order to have the patient immobilized, no matter whether you are doing your procedure under local anesthesia, under sedation, or under general anesthesia. Robotics have been to our lives. It's not something new. We have robotics for more than a couple of decades. This is one of the first publications back in 2006 about robotic implementation for tumor ablation. 2008, in vivo experiment about stereotactic CT-guided percutaneous stabilization for posterior pelvic ring fractures. That was a preclinical cadaveric study showing feasibility of utilizing robotics in MSK procedures. We go back to 2014, orthopedic surgeons are now becoming familiar with robotics for percutaneous vertebroplasty, and what they're reporting is something we commonly find in all our papers: significant reductions in dose radiation, significant reduction in the duration of the procedure. Now we are in 2025, new generation of robots, once again on a musculoskeletal system, percutaneous needle placement in bone with a table and a floor-mounted robotic devices. In my talk, I'm going to focus about the application of cone beam CT for needle navigation, utilization of needle guidance software as the ones you can find in the angio or the CT suites, fusion imaging, virtual navigation, electromagnetic navigation systems, robotics, and augmented reality or hybrid approaches. The common thing that all of these systems do have is that they are reducing the duration of the procedure. They are reducing the radiation dose both for the patient and for the operation. They are standardizing the procedure. They are turning the procedure in more democratic fashion, meaning that both experienced and novice users, they have the same outcomes. And last but not least, and we're going to speak briefly about that, they will offer you verification of margins. These are the main conclusions, and exactly this is the rationale why to use navigation systems in our everyday clinical practice. They are reproducible, they are safe, they offer high precision, they are performed nowadays at acceptable costs and efforts, they can enable mixed reality environments, and they can be autonomous, and they offer shortened duration and reduced radiation exposure reduction. All these pillars, they are changing a subjective to an objective performance of a clinical procedure, of a therapy like ablation, for example. Starting with cone beam CT, for reasons that go beyond my comprehensive, cone beam CT is not used enough in our clinical practice. It's a great tool. It offers greater accuracy for complex needle pathways. It offers improved targeting in the presence of metal artifact, enhanced visualization during injection of contrast medium or cement, increased ease when the space in the gantry is limited, and reduced the radiation dose compared to the standard computed tomography scans. If you combine cone beam CT with available softwares like the one you see in the current example, you can delineate the tumor. You can have anatomical lines specifically for orthopedic procedures, but also for the liver or in the lung. You can delineate the tumor, decide how much cement you are going to inject. You can delineate the presence of the nerves and other sensitive anatomic structures. And thus you can have a very good outcome, which I'm going to repeat that during my talk. It's going to be standardized in every single day. Moving on from cone beam CT to needle navigation softwares, you can use lasers which are embedded in your everyday CT scans. These kind of lasers, you find them in different vendors. This is an example from Siemens Varian, which was the first integrated CT laser for computed tomography guided interventions. The benefits are more or less the same. Increased needle accuracy, reduced radiation, increased standardization of the procedure, less repositioning of the needle, making the procedure standardized, faster, repeatable. And you can see this is a paper coming from Germany. Using my needle laser has resulted in increased efficiency. The planning time was reduced by 33%. The intervention time was reduced by 39%. Reduced radiation dose was up to 65% and improved accuracy with less needle repositionings. Apart from laser, we also have fusion imaging. We can fuse information achieved from different imaging modalities. In these cases, you are having computed tomography and MRI side by side with real-time ultrasound. Apart from fusion imaging, which has its own drawbacks, you can use virtual devices on ultrasound. You can have V or E tracks, electromagnetic sensors. The one is embedded in the needle, the other is embedded in the probe, and you can perform all kinds of procedures, including bone biopsies or bone ablation, under utilization of these virtual devices. Moving on to navigation systems, we have three different families in the navigation systems. We can have patient-mounted, floor-mounted, or table-mounted device, depending where the device is actually placed, on the patient, on the gantry, or on the floor of the room. Keep in mind, patient-mounted devices, they are less susceptible to patient movement. Even if the patient moves, the device is on the patient, therefore the relationship between the two remains more or less the same. Therefore, patient-mounted devices can easily, or I would say easier, be used under local anesthesia. If you are moving from patient to floor-mounted or table-mounted devices, then you are in need for sedation or even better for general anesthesia. You should use the mattresses in order to have patient immobilized. Even the slightest movement of the patient will change the relationship and you will have decreases in the accuracy of the system. Starting with patient-mounted devices, one of the first devices was the Cube device. You can place it on the patient. You can perform all kinds of procedures utilizing very thin needles up to 22 gauge, or you can use larger diameter needles, including bone trocars up to 8 or 10 gouges. One very common system is the IMACTIS system. It's an electromagnetic navigation system which can be used for all different procedures performed either under computed tomography or under cone beam CT in the angio suite. Studies out there, they are showing that this is a universal system which eliminates variability both for simple and complex procedures, creating standardized approaches and demonstrating better patient outcomes. The good thing about the IMACTIS system, it's a patient-mounted device. It doesn't have general anesthesia as a prerequisite. The fiducial is placed on the patient. Inside the fiducial, you have both the geometric markers and the emitter that generates an electromagnetic field. Simply because this is an electromagnetic device, you are working outside the gantry. Inside the gantry, it's two metal, which is going to create artifact, which will interfere with your electromagnetic system. One recent paper about feasibility and technical development of the electromagnetic navigation system in percutaneous pelvic bone cementoplasty. 33 patients, needle repositioning was required in just a single case. This is a small renal cancer tumor in the upper pole of the left kidney. We needed a double oblique approach. We used the MACT system in order to puncture with accuracy the small tumor in a very challenging location. Another feature of the MACT system is the marker. You can use that for tumors which are not visible without contrast medium injection. This is a case, patient with hepatocellular carcinoma, previously treated with a combined approach, microwave plus transarterial chemoembolization. You can see the lipiodol remaining in the liver 2 years after the initial treatment. There was a small tumor recurrence, 1 centimeter in diameter, which was not visible without contrast medium injection. Therefore, we used the marker. We injected contrast medium. We placed the marker on the level of the tumor, and the marker was our subsequent tumor target in all the subsequent phases that we couldn't see the tumor itself. We performed microwave ablation with utilization of this software. This is the end result with margins. 6 months after PET-CT shows lack of any tumor avidity, total tumor necrosis, successful microwave ablation result. Even most interesting from technical point of view, the total duration from patient entrance to patient exit was 55 minutes. We performed 13 scan numbers, and see that the triple phase in the beginning, the triple phase in the end for margins verification, if you take these 6 phases, these 6 scans out, that leaves us with just 7 scans for tumor ablation. Specific durations, the planning time was 7 minutes, the needle insertion time was 12 minutes in a pretty challenging location in the liver dome, 10 minutes of ablation time, and 3 minutes for the immediate imaging follow-up. Moving on to table-mounted and floor-mounted robotics, experiments have shown that they can be used under general anesthesia to increase needle navigation. This is a table-mounted robotic system, one that we are using in the department. You can see the setup, the matrix that is used for patient immobilization. I'm not going to extend in this. This is the workflow for robotics. Briefly, you have the patient immobilized. You need to calibrate the robot. You're performing your CT scan. You are sending the images from your computed tomography to the robot. The robot places the robotic arm in place, and then you're performing your procedure utilizing the robot, no matter whether it is a biopsy or an ablation. For all these devices, the learning curve is pretty short. You need something like 7 or 8 initial cases, and then you can see that your accuracy increases, the duration of the procedure decreases, the radiation exposure decreases. Once again, too many studies utilizing robots for biopsies, for ablation in the lung, in the bone. They saw exactly the same thing. These are user-friendly systems with a steep learning curve. They offer real-time visualization of the needle. They offer increased precision compared to the freehand approach, less needle repositioning. Most importantly, they democratize the procedure, offering the same chances of success between novice and experienced users. They standardize the procedure, resulting in the same outcome. Obviously, there's a dark side in the force. Sometimes, especially during the learning curve, you are related with longer procedural times, though you get an increase in the CT scan numbers. I need to say here that the amazing thing about these systems is that you can use them not only on your computed tomography suite, but also on your angio suite. They are compatible with cone beam CT. Therefore, you can perform different procedures in different settings depending on your familiarity with different setups. Specifically about the table-mounted robot, studies have shown that the average case reduction is approximately 20%. The average radiation exposure reduction was 44%. The alignment trajectory, meaning needle accuracy, was ranging from 0.32 to 0.65, and the needle tip location success was 0.54 millimeters, less than 1 millimeter. Different cases, tumor ablation in the thoracic wall, tumor ablation in kidney tumors, or a metastatic lesion in the soft tissues performed. These are cases that we actually did during our learning curve. These are 3 out of the 7 initial cases we did. The first 4 were percutaneous biopsies. In the same 2 days time, we moved on, performing 3 different ablations. Obviously, when you are in your learning curve, you want to start with chip shots, easy cases that you would do with your free hand in order to familiarize yourself with this kind of systems. Somebody might wonder why spending money in a bucket without bottom, especially if you're going to need systems for navigation, systems for ablation simulation, systems for margins verification. And right now in the market, you have different robotic systems which offer 3-to-1. One of these systems is the calcination robot, offers you ablation simulation as the one you have seen in this patient with liposarcoma. The system offers needle navigation. You can see the cryoprobes placed in the tumor, the ice ball, and of course, margins verification, which are necessary in order to prove that you have succeeded an A0 ablation. Last but not least, we have hybrid approaches. This is a mini endoscope. We have used it with computed tomography. It takes just a single 16-gauge trocar. You can place the mini endoscope inside the trocar. This is a case of splanchnic nerve cryoneurolysis. You can see that the splanchnic nerve actually is in the tip of your needle, and you can proceed with cryoneurolysis, knowing that you will end up with a successful outcome. Obviously, you need to familiarize yourself with endoscopic imaging. This is something that we need to get better training in order to achieve that. Last but not least, augmented reality is going to come in our everyday clinical practice. Some case examples and studies in the literature published in 2022, you can see that you can use augmented reality for a wide variety of different procedures. Concluding, we need margins verification, and these systems should and will offer softwares for margins verification. It has been shown that no matter the size of the tumor to be treated, if you achieve 3-dimensional margins, you will have very good surgical equivalent results. This is a meta-analysis and systemic review of the literature, highlighting the importance of margins for colorectal cancer liver mets. The importance of margins verification has been highlighted for so many different other pathologies, including hepatocellular carcinoma. This is one of the most interesting trials, the ACCLAIM study, coming from the United States with centers in Europe as well, focusing on margins verification for colorectal liver metastatic disease ablation with microwave energy. And the results of this study are eagerly awaited. So, in your everyday clinical practice, you will need to use this kind of softwares in order to be able to verify that you have 3-dimensional margins. Studies out there have shown that when you do the evaluation with your own eye, the success is not as high as when you are using this kind of softwares, which makes sense because these softwares are actually standardizing the procedure. Closing up, navigation systems, different softwares, lasers, robotic systems, they are here, they're going to stay. The rationale to use this kind of systems include the fact that they radically improve your workflow, they're decreasing procedural time and radiation exposure, they're useful for double oblique out-of-the-box approaches, they're improving accuracy, and they're decreasing variability. Always remember, these kind of systems are not a panacea, they are not a remedy for any kind of disease. They are here, but they are not going to substitute your clinical thinking. They are here to help you perform in a more democratic, in a more standardized way. Thank you so much.